Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module we are going to deal about the human menopausal gonadotropin and the most important complication of human menopausal gonadotropin, that is ovarian hyperstimulation syndrome. So this ovarian hyperstimulation syndrome and human menopausal gonadotropin is basically a very controversial topic which is more prevalent among the students. So I thought, why not we take this as a separate module in Mackler, right? So that it would be very easy for you for your theory as well as for your MCQ examinations. Is that clear? Okay, so let's start with the topic now. So basically, this human menopausal gonadotropin is prepared from the urine of menopausal female. So who are menopausal females? So menopausal females are those groups of female who have permanently been stopped of menstruation. So permanent cessation of menstruation for a period of about 1 year is termed as menopause. So those females who are permanently stopped from menstruating, those are the menopausal age group female. So in those females who have attained this menopause, from the urine of those menopausal females, this is actually prepared. So what is the actual preparation of this human menopausal gonadotropin? So human menopausal gonadotropin contains follicular stimulating hormone and luteinizing hormone. So you may think that why it is containing follicular stimulating hormone and luteinizing hormone. The basic principle behind this human menopausal gonadotropin is to promote the follicular maturation. So once the follicle is going to get matured, it is going to stimulate the ovulation, and once the ovulation is getting stimulated, the mature ovum will get released. So ideally, the major function of this human menopausal gonadotropin is to stimulate the ovulation. So this is a ovulation inducing drug, but then it is not the primary drug of choice to treat infertility through ovulation inducing drugs. But then human menopausal gonadotropin is a group of ovulation inducing drugs which are basically prepared from the urine of menopausal females. Okay, so it contains follicular stimulating hormone and luteinizing hormone. Right. So how is the preparation of human menopausal gonadotropin? It is actually a lyophilized preparation. What do you mean by a lyophilized preparation? It is actually freeze dried. So it is basically a very sterile white powder. So human menopausal gonadotropin is a white clear sterile powder. So to that powder you have to mix about sodium chloride and then you inject this human menopausal gonadotropin in those females in whom you have to induce the ovulation. So what is the route of administration? The route is intramuscular followed by subcutaneous. Either you can give intramuscular or you can give subcutaneous as well. And the most important side effect of the most common side effect of human menopausal gonadotropin is pain at the injection site. So at the injection site there will be pain, which is the most common symptom, followed by headache. So pain at the injection site and headache are the most common symptoms of human menopausal gonadotropin. The route of administration is intramuscular followed by subcutaneous, and it is basically a lyophilized freeze-dried preparation. So it is basically a sterile white powder preparation. Is that clear? Okay. As you can see in this image, so this is the human menopausal gonadotropin, the white color powder, and this is the solution sodium chloride with which you have to mix it and then you have to inject it into the female through the intramuscular route. Is that clear until now? Yes. Okay. So basically it is an ovulation inducing drugs. So in those females who have trained through in vitro fertilization, artificial reproductive techniques such as in vitro fertilization, so in those groups of female also this human menopausal gonadotropin is tried. Why? Because it is the ovulation inducing drug. So since it is an ovulation inducing drug, human menopausal gonadotropin is also tried in IVF cycles as well. Is that clear? Okay. So now let me give you a question here. So in patients with intact hypothalamo-pituitary axis, you can give two important drugs. I'm repeating it again. In patients who have intact hypothalamo-pituitary axis, you can give two drugs for the purpose of ovulation induction. So before that, you tell me what is intact hypothalamo-pituitary axis. Intact means both the hypothalamus and the pituitary are functional in a female. If they are going to be functional, then definitely the GnRH will get released from the hypothalamus, which will act upon the anterior pituitary and it will release the follicular stimulating hormone and the luteinizing hormone. So in those females where the hypothalamus and pituitary are intact and functional, in those females you can administer two drugs for the purpose of ovulation induction, and those drugs are letrozole and clomiphene citrate. So in the previous module, I told you that in patients of PCOS, the drug of choice for ovulation induction is letrozole followed by clomiphene citrate. But in general, overall, the most commonly used drug for the purpose of ovulation induction is clomiphene citrate. So clomiphene citrate is the most commonly used drug for ovulation induction overall. And letrozole is also the most important and most commonly used drug for the purpose of ovulation induction in patients with PCOS. So both these drugs, letrozole and clomiphene, can only be used in a patient with intact hypothalamo-pituitary axis, right? But in case if the hypothalamus or the pituitary are not intact or they are not functional, you cannot use letrozole or clomiphene citrate in those patients. See, the first line treatment of choice for ovulation induction is letrozole and clomiphene citrate. Is that clear? The first line drug of choice for the purpose of ovulation induction is letrozole and clomiphene citrate, and the indication for using this drug is intact hypothalamo-pituitary axis. But in case if the hypothalamus or the pituitary is not intact or it is not functional, you cannot use this first line drug letrozole or clomiphene citrate. So in those patients where the hypothalamus or the pituitary is not intact, in that group of females, you have to use human menopausal gonadotropin, which is the second line of treatment for ovulation induction. So what was the actual indication of human menopausal gonadotropin? Failure of treatment with letrozole and clomiphene citrate, or in patients where letrozole or clomiphene citrate cannot be used. So who are those group of females in whom letrozole or clomiphene citrate cannot be used? Those are those females in whom the hypothalamus or the pituitary is not intact. So let me give you an example here. So this is hypothalamus, this is anterior pituitary. From the anterior pituitary, from the hypothalamus, GnRH will get released. GnRH will act upon the anterior ovary. GnRH will act upon the anterior pituitary. From the anterior pituitary, follicular stimulating hormone and luteinizing hormone will get released, and this FSH and LH will act upon the ovary, and it will result in the release of estrogen, progesterone, androgens, and etc. So let me repeat it once again. From the hypothalamus, GnRH will get released. This GnRH will act upon the anterior pituitary, and from the anterior pituitary, the follicular stimulating hormone and luteinizing hormone will get released. This FSH and LH will act upon the ovary, and it will result in the release of estrogen, progesterone, androgens, and etc. Right? But in case if the hypothalamus is not intact, or if the anterior pituitary is not intact, you cannot use letrozole or clomiphene citrate for ovulation induction. What is the example? Hypothalamic failure, which is called as Kallmann syndrome, right? Or in patients in whom the pituitary has been ablated. So in pituitary ablated patients and in patients with Kallmann syndrome, in whom the hypothalamus pituitary axis is not intact, in those group of female you cannot use letrozole or clomiphene citrate, and in those patients the drug is human menopausal gonadotropin. Is that clear? Yes, good. Now we are going to discuss about human menopausal gonadotropin. So until now we have discussed that it is prepared from the urine of menopausal female, and it is basically a lyophilized preparation, freeze-dried powder. It is white in appearance, and the most common side effect is pain at the injection site followed by headache, and the route of administration is intramuscular and subcutaneous. Now, what is the actual protocol for administering this human menopausal gonadotropin? So this protocol is called as step-up protocol. Step-up protocol. So what do you mean by step-up protocol? You have to administer this drug in a step-up manner. So you have to do controlled ovarian stimulation. So it means that you have to administer this drug and you have to do some monitoring. And after it is normal, you have to just step up with the drug and you have to do some monitoring, and you can next step up and step up. So basically it is a step up protocol. The main purpose is to do controlled ovarian stimulation. In order to prevent ovarian hyperstimulation syndrome, you have to do controlled ovarian stimulation with human menopausal gonadotropin. So this human menopausal gonadotropin, the HMG, contains about 75 international units of FSH and LH. Is that clear? 75 international units of FSH and LH. And this is given for around 12 days. This is given for around 12 days. So for this 12 days, step-up protocol is actually followed. So what is the main purpose is that, as I told you earlier, multiple follicles will start growing. So the major purpose is to mature the ovarian follicles and stimulate the ovulation. So once you administer this human menopausal gonadotropin to a female, then multiple ovarian follicles will start to grow. And it is very certain that this ovarian follicles are going to release estrogen, estradiol, which is E2. And the amount of estrogen released by this immature ovarian follicle is around 200 picogram. See, these are directly proportional to each other. That is, see, this is the ovary, and the ovary contains multiple ovarian follicles, and I'm telling you that each of this ovarian follicle is going to release 200 picogram. So it indirectly means that if I'm going to measure the E2 level, if the E2 level is increased, then it means that there are increased amount of ovarian follicles which are growing in the ovary. So it is proportional to each other. Am I right? See, I'm telling you that each of the ovarian follicle is going to release about 200 picogram of estradiol, which is estrogen. So if I'm going to check the level of estradiol in a female, if the levels of estradiol are increased in that female, then it means that multiple ovarian follicles are actually growing in the ovary. So it means that there are chances for this ovary to get hyperstimulated. So that is a risk of ovarian hyperstimulation syndrome. So I have written it here very clearly. So if the E2 increases, it means that multiple ovarian follicles are growing and will mature. So if multiple ovarian follicles are going to grow and mature, it is going to result in ovarian hyperstimulation syndrome. Is that clear? Okay, fine. So as per the step-up protocol and controlled ovarian stimulation, what are you supposed to do is that you have to give injection HMG, human menopausal gonadotropin, 75 international units for around 12 days, and you have to do step-up protocol in these 12 days, right? So whenever you're going to administer this drug, you have to do two things. One thing is that you have to monitor the estradiol levels, that is E2 levels, and you have to do follicular monitoring. So you do the follicular monitoring and you measure the estradiol level. Why are you going to measure the estradiol level? Because if the estradiol E2 level is increased, then it means that the number of ovarian follicles in the ovary is actually increased. So definitely you have to do follicular monitoring and you have to do serum estradiol level in that female as well. So once the number of ovarian follicles in the ovary is more than equal to 3 and the size of this ovarian follicle is more than equal to 17 millimeter and the serum estradiol level in the female is between 500 to 1500 picogram per ml, it is the ideal time that you have to give an ovulation trigger for the purpose to stimulate the ovulation. Is that clear? You have to stimulate the ovulation, and for that purpose you are going to give ovulation trigger with a drug which is called as human chorionic gonadotropin. Is that clear? Human chorionic gonadotropin is the drug which you are going to give for ovulation trigger. See, it's very simple. You are going to give human menopausal gonadotropin to females in whom you have to do this ovulation induction. So you have given this human menopausal gonadotropin, and as per the step-up protocol, you have to do serial follicular monitoring along with serum estradiol level measurement in that female. So once while doing this follicular monitoring and measuring this estradiol level in females, if the number of ovarian follicles on follicular monitoring is more than equal to 3 and the size of this ovarian follicle is more than equal to 17 millimeter in diameter and the serum estradiol level is somewhere between 500 to 1500 picogram per ml, then it means that it is the ideal time to stimulate this ovulation. So how are you going to stimulate the ovulation? I have to give an ovulation trigger. You have to trigger the ovulation, and this ovulation trigger can be done with the human chorionic gonadotropin. human chorionic gonadotropin. So once you are going to give injection human chorionic gonadotropin, then finally ovulation is going to happen, because the ovulation will get stimulated and there will be release of mature ovum. So after giving this human chorionic gonadotropin, approximately about 36 hours after giving this ovulation trigger, ovulation will happen, where the mature ovum will get released from the ovary. Is that clear until now? So the basic process is where you give HMG, followed by you do the serial follicular monitoring and estradiol measurement, and you check it appropriately and do the step-up approach. And once you are given it for 12 days, and once the number of follicle is more than equal to 3 and the size of the follicle is more than equal to 17 millimeter and the serum estradiol level is between 500 to 1500 picogram, it is the ideal time for ovulation trigger, where you are going to give injection HCG, and about 36 hours after giving this ovulation trigger, ovulation will happen. Is that clear? Yes. So this is the basic about this ovulation induction with injection human menopausal gonadotropin. Now coming to the most important complication of human menopausal gonadotropin. See, since there are risk for multiple ovarian follicles to get stimulated and grow, if multiple ovarian follicles will grow and mature, then there are chances that the ovary is going to contain multiple ovarian follicles. If multiple ovarian follicles are going to present in the ovary, then therefore the amount of estradiol which is going to be released by each of this ovarian follicle is going to be 200 picogram. Since they are multiple in number, the estradiol will be somewhere around 2500 picogram per ml, which is higher than the 500 to 1500 range. The normal is 500 to 1500 range, but in those patients with hyperstimulated ovary where the number of follicles are increased in number, since each of this follicle is going to release about 200 picogram of estradiol, therefore the estradiol levels will increase. It will be somewhere around 2500 picogram per ml, which is higher than the normal range. And if the estradiol is 2500 picogram, and if the clinician or the doctor fails to notice this estradiol level and by mistake you're going to give this ovulation trigger, that is injection HCG, to this patient, there are increased chances of ovarian hyperstimulation syndrome. So let me make it very clear for you. See, you're going to give injection human menopausal gonadotropin to the female. So once you give human menopausal gonadotropin, multiple follicles will start to grow. Since multiple follicles will start to grow, the amount of estrogen which is going to be released by each of the follicle is 200. If multiple follicles are growing, then the estrogen level will be somewhere around 2500 or even more than that. Yes, or even more than that, which is higher than the normal range. And I told you that you have to do step-up approach where you need to monitor the follicular monitoring and you have to measure the serum estradiol level. But if you fail to monitor the serum estradiol level, which is more than 2500 picogram per ml in this patient, and without monitoring this estradiol level, if you're going to administer injection HCG as ovulation trigger, then it will lead to ovarian hyperstimulation syndrome, because the main purpose of HCG is to act as an ovulation trigger. So since it acts as an ovulation trigger, the ovary will get hyperstimulated, which is called as ovarian hyperstimulation syndrome. So this complication of ovarian hyperstimulation syndrome in patients of human menopausal gonadotropin is actually an iatrogenic complication. It's an iatrogenic complication. So how will you prevent this complication? It is through you have to do two important monitoring when you administer injection human menopausal gonadotropin. One is that you have to do serial follicular monitoring. Do serial follicular monitoring. So if you do serial follicular monitoring, you can observe the multiple ovarian follicles if present or not. And apart from that, you have to measure the serum estradiol levels. So if the serum estradiol level is going to be more than 2500 picogram per ml, then it is the time where you have to withhold this injection HCG. Because if I'm going to give injection HCG as ovulation trigger in a patient where the estradiol level is more than 2500 picogram, it is going to result in ovarian hyperstimulation syndrome. So in order to prevent this iatrogenic complication, I have to withhold injection HCG as the ovulation trigger. So you just withhold the injection HCG, right? and this will prevent the iatrogenic complication, that is ovarian hyperstimulation syndrome. So the major way to prevent this is through three ways. Once you give injection HMG to a patient for ovulation induction, do serial follicular monitoring, and then also do serum estradiol monitoring, and then also if in case the estradiol level is more than 2500 picogram, then please withhold this injection HCG. Injection HCG has to be withheld. Is that clear? Yes. Now, how it will lead to ovarian hyperstimulation syndrome. So, okay, I understand now that the ovary is getting hyperstimulated because you gave this ovulation trigger. So, because of that reason, the ovary is getting hyperstimulated. But what is this actual syndrome called as? The ovary is getting hyperstimulated, so it is ovarian hyperstimulation. But why it is called as a syndrome? Because it presents with some typical clinical manifestations, and that is that when the estrogen levels, that is estradiol level, is going to be more than 2500 picogram per ml, which means that multiple follicles are growing. And if injection HCG is given mistakenly, what is going to happen is all the follicles will start to rupture. So since the follicles which are present in the ovary is going to rupture, once this follicle is going to rupture, it is going to result in the release of vascular endothelial growth factor. So once this vascular endothelial growth factor is going to get released, it increases the capillary permeability. See, you have given injection HMG, and followed by that you did not do the serial estradiol monitoring, and the estradiol level is more than 2500 picogram per ml, and mistakenly you have given injection HCG. Since you have given injection HCG mistakenly, it is going to result in ovarian hyperstimulation syndrome. But how it happens is that injection HCG has been given mistakenly. So since the ovary is getting hyperstimulated, it is going to result in rupture of all the follicles which are present in the ovary. So once these follicles are going to rupture, it is going to result in the release of vascular endothelial growth factor. So this vascular endothelial growth factor, which is popularly known as VEGF, it is going to increase the capillary permeability. Since the capillary permeability is increased, it is going to result in the collection of the fluid in the third space. So all the fluids will collect in the third space, which will present to us clinically as hydrothorax and ascites. Ascites is basically peritoneal fluid correction, and hydrothorax is when the pleural cavity is filled with fluid. So hydrothorax and ascites will result as a clinical manifestation. And since the because of increase in capillary permeability, all the fluids are getting collected in the third space, therefore it is going to result in hemoconcentration. It is going to result in hemoconcentration because all the fluid has collected in the third space. Since all the fluid has been lost, it is going to result in hemoconcentration. So since hemoconcentration is going to occur in the blood vessel, there are increased risk of thrombosis. So this is the typical clinical manifestation of ovarian hyperstimulation syndrome. So the basic manifestation is when you have given injection HMG, followed by you did not do the estradiol monitoring, or you did the estradiol monitoring but then mistakenly you have given injection HCG as an ovulation trigger. So since you gave the ovulation trigger, the ovary will get hyperstimulated, and all the follicles which are present in the ovary is going to rupture. And once the follicles rupture, it is going to result in the release of vascular endothelial growth factor, which will increase the capillary permeability. And once the capillary permeability is going to get increased, it is going to result in collection of the fluid in the third space, which is the hydrothorax and ascites, followed by it is going to result in hemoconcentration in the blood vessels. Since the blood vessels get hemoconcentrated, there are increased risk of thrombosis. Clear? Yes. So now this ovarian hyperstimulation syndrome can actually be categorized into two types. One is early ovarian hyperstimulation syndrome, and the second one is late ovarian hyperstimulation syndrome. So what do you mean by early and late ovarian hyperstimulation syndrome? If ovarian hyperstimulation syndrome occurs within 9 days of injection HCG, that is, you have given injection HCG as ovulation trigger. If all the symptom complex occurs within 9 days of injection HCG, it is early ovarian hyperstimulation syndrome. But if all this arise more than equal to 9 days after administering injection HCG as ovulation trigger, it is called as late ovarian hyperstimulation syndrome. So Where will you observe this late ovarian hyperstimulation syndrome? See, basically early ovarian hyperstimulation syndrome is more common than late ovarian hyperstimulation syndrome, right? But late ovarian hyperstimulation syndrome, where this syndrome is going to appear more than equal to 9 days after giving injection HCG as ovulation trigger to the patient, is when you have given injection HMG for the ovulation inducing drug to the patient, and followed by that you have given injection HCG as ovulation trigger to this patient. But then the patient has conceived now. Since the patient has conceived now, during the pregnancy, we all know that the hormone which is going to be increased is human chorionic gonadotropin. See, you have given injection HMG for ovulation induction purpose, and then you have given injection HCG for ovulation trigger. During this phase of injection HCG and during this phase of 9 days, within 9 days of giving injection HCG, there is no problem. The patient is absolutely alright. But then if the patient is going to get conceived after receiving this injection HCG, then during pregnancy there are increased chances for development of ovarian hyperstimulation syndrome. Why? Because is that in pregnancy, we all know that the hormone which is going to be increased is human chorionic gonadotropin HCG, which is basically produced by the placenta. Since HCG acts as an ovulation trigger, so giving HCG is increased throughout the pregnancy, right? So since HCG is increased in pregnancy, it is going to worsen the ovarian hyperstimulation syndrome. So development of all this symptom complex more than equal to 9 days of giving injection HCG is basically due to pregnancy, because during pregnancy HCG levels will increase further, and this HCG levels which are increased during pregnancy will further worsen the ovarian hyperstimulation syndrome. So basically the late ovarian hyperstimulation syndrome is basically due to the increased levels of HCG in pregnant females. Since HCG is increased during pregnancy, this increased HCG is going to result in rupture of all the follicles in the ovary, and it is going to result in the release of vasculoendothelial growth factor followed by collection of the fluids, hemoconcentration, and the risk of thrombosis. Is that clear? Let me repeat it once again. See, we have early and late. Early is when the syndrome develops within 9 days of injection HCG. Late is when you have given injection HCG and within 9 days no symptoms arise. But after 9 days, the symptoms are happening, the syndrome is happening, and the main reason for this is that the patient has received injection HMG and HCG for ovulation induction and ovulation trigger. But then by chance the patient has got conceived. So since he got conceived, and since the ovary has multiple amount of follicles being present, and now she has conceived, during conception we know that the hormone which is increased is human chorionic gonadotropin, which is released by the placenta. Since HCG is increased during pregnancy, this increased HCG level is going to result in hyperstimulation of the ovary, and it will release the vasculoendothelial growth factor, and therefore the syndrome is going to happen. So that is ovarian hyperstimulation syndrome, which happens more than equal to 9 days. Clear? This is early and late ovarian hyperstimulation syndrome. Now let's go to the symptom complex. The most common symptom is going to be the abdominal pain. Abdominal pain is the most important and most common symptom the patient is going to present to you, followed by nausea and vomiting. Right? Abdominal pain, because the follicles are getting ruptured, so the patient might have some sort of abdominal pain. So abdominal pain, nausea, vomiting, all these would be the presenting complaint of patients with ovarian hyperstimulation syndrome. See, basically ovarian hyperstimulation syndrome is a clinical diagnosis. You need not require any particular investigation in order to come to a confirmatory diagnosis. But then if you are going to do transvaginal sonography in a patient of ovarian hyperstimulation syndrome, what you will be able to see is large multiple ovarian follicles which are situated diffusely in ultrasound. As you can see here large multiple ovarian follicles are seen in the ovary diffusely present. So presence of large multiple ovarian follicles in the ovary on transvaginal sonography is towards the diagnosis of ovarian hyperstimulation syndrome. So basically the ovary has multiple number of follicles, and because of ovulation trigger when the E2 level is more than 2500, which means that multiple amount of follicles are present in the ovary, and if you're going to give ovulation trigger at this point of time, it is going to result in a rupture of all these follicles, and it is going to result in the release of vasculoendothelial growth factor, which will increase the capillary permeability and result in collection of fluid in the third spaces and hemoconcentration in the blood vessels, which will increase the risk of thrombosis in that patients. So for that reason, you have to do serial follicular monitoring, and then you have to do serial estradiol monitoring depending upon the patient. Right? Clear. Now, we have a particular grading for this ovarian hyperstimulation syndrome, where the grades are mild, moderate and severe. So grade 1 and 2 are mild, 3 is moderate, 4 and 5 is severe. Clear? 1, 2 is mild, 3 is moderate, 4, 5 is severe. So grade 1 is when the patient is going to complain to you with some complaints like abdominal pain, discomfort and distension. Right? Abdominal pain could majorly be due to the rupture of the ovarian follicles and due to the collection of fluid in the peritoneum as well as in the pleural cavity. Right? So because of distension, the patient might have some discomfort and pain. So grade 1 is all about abdominal distension and pain. Grade 2 is when, along with the abdominal pain and distension, the patient is going to have nausea and vomiting. So nausea, vomiting along with abdominal distension is grade 2. So both this grade 1 and grade 2 is mild ovarian hyperstimulation syndrome. So moderate belongs to grade 3. So grade 3 is when, along with the abdominal pain, distension, nausea and vomiting, if the patient is going to have collection of this fluid in the peritoneal cavity, which is called as ascites, it is moderate or grade 3 ovarian hyperstimulation syndrome. So please remember, when does ascites occurs in ovarian hyperstimulation syndrome? It is grade 3 or a moderate ovarian hyperstimulation syndrome. Grade 4 and grade 5 belongs to severe ovarian hyperstimulation syndrome. Grade 4 is when, along with the moderate ovarian hyperstimulation syndrome, there is collection of fluid in the pleural cavity and in the pericardial cavity. So it is pleural effusion and pericardial effusion. So ascites belongs to grade 3, pleural and pericardial effusion belongs to grade 4. Grade 5 is when, along with the grade 4, there are some biochemical alterations in the form of hemoconcentration, increased risk of thrombosis, coagulopathy, deranged liver and kidney function test. Is that clear? Grade 1, 2, 3, 4 and 5. So it's very simple. Grade 1 and 2 is all about the symptoms. Grade 3 is development of ascites. Grade 4 is development of pleural and pericardial effusion. Grade 5 is the development of hemoconcentration, hypercoagulability, deranged LFT and RFT. So please take a screenshot of this. So writing this in your particular examination will amount you to some extra marks as well. So please take a screenshot of this. Right? Okay. Now, finally coming to the management of ovarian hyperstimulation syndrome. So we have basically divided this patient into mild and moderate to severe. So mild patients will require different sort of management, and moderate to severe cases will require different sort of management. So mild patients, you have to just reassure the patient and ask the patient to be in rest. No admission, no hospital admission is required in patients of mild ovarian hyperstimulation syndrome. You have to just reassure the patient, ask the patient to be in rest and do conservative management. So what is the conservative management? You have to give analgesic for abdominal pain, antiemetics for nausea and vomiting. And apart from that, you just ask the patient to avoid any heavy weight lifting, any strenuous activity, avoid coitus with her partner, because all these sort of things can lead to rupture of the ovary, and once the ovary is going to get ruptured, it is going to result in release of vasculoendothelial growth factor, which is the main culprit here, and it will result in collection of fluid in the third space, hemoconcentration and increased risk of thrombosis as well. Right? Okay, so no admission is required for mild cases, but for moderate to severe ovarian hyperstimulation syndrome, hospital admission is therefore required. So put the patient in admission, ask the patient to be in rest, reassure the patient, administer IV fluids to the patient in order to maintain fluid balance, and please check the serum electrolytes, and if there is some electrolyte imbalance, correct it. So please maintain this fluid and electrolyte balance, and in case if the patient is having ascites, which is grade 3 or moderate ovarian hyperstimulation syndrome, do the procedures, that is paracentesis, in order to remove the fluid from the peritoneal cavity, right? And apart from that, the most important prophylaxis which you do in patients of moderate to severe ovarian hyperstimulation syndrome is thromboprophylaxis. I told you that in patients of ovarian hyperstimulation syndrome, because of increase in capillary permeability, all the fluids will leak and get settled in the third space. So since all the fluids have been leaked, therefore hemoconcentration is going to happen, which is going to result in increase in viscosity of the blood. So because of increase in viscosity of the blood, there is increased chances of thrombosis. So in order to prevent this thrombosis, prophylactically you have to administer heparin in patients of moderate to severe ovarian hyperstimulation syndrome. So thromboprophylaxis, where you administer heparin to prevent thrombosis, is the prophylaxis which is done in patients of moderate to severe ovarian hyperstimulation syndrome. Fine. So until now we have discussed about human menopausal gonadotropin and the most common complications and how is the investigation done and what is the grading and the management of ovarian hyperstimulation syndrome. Now we have the case discussion of ovarian hyperstimulation syndrome, and I feel that this is much for you to understand in a single module. Is that clear? Right? We have done so much today, and this would be very particular, and I have been very concise towards this topic, and I made it very simple for you. So in the next module we'll be discussing about the case presentation of ovarian hyperstimulation syndrome. This is basically a clinical case where we are going to solve this clinical case and we are going to give the management. So this will be done in the next subsequent module. So I hope that I have been very concise and clear with respect to ovarian hyperstimulation syndrome and human menopausal gonadotropin. In case if you have any doubt with respect to this topic, please write to us in the Mackler handle. I will reach out to you as early as possible. So thank you. Let's meet in the next module where we'll be solving the case.